All right. We've been talking quite a bit off and on today about essentially what you might call measuring decision quality. That might not have been exactly what you thought we were talking about, but in different ways people referred to things like, how can we tell when decisions are made? How can we hold people accountable for doing the right thing in the process of decision making? And for a long time, the Foundation has been really worried about the problem of measuring the decision quality, and there's some pretty obvious reasons for that. There are basically three. First of all, we've been in the business of trying to improve decisions for a long time, developing different tools, developing different strategies for helping people, and obviously we felt like we needed ways to find out if we're doing better or worse, or how well we're doing. So we certainly needed it for, if you might call, quality improvement and evaluation purposes for the things we were trying to do. A second thing that obviously has come up in the discussion today, and we hear more and more about, is that if we're going to try to encourage providers and health systems and others to improve the quality of decision making, then we also need tools so we could measure that, so we could tell who's doing it well and who's doing it less well. However you're going to use it, whether you're going to affect how much you pay or what you pay for, whether you're going to give people gold stars, whether you're just going to make public information of one sort or another. You need tools and measures that are widely accepted. And third, there's actually an internal value in measuring how well you're doing, and also what patients know and what they care about, and that's that it can help deliver better medical care. That by having ways of collecting particularly what people know and what they care about that are reliable, you can collect that data and feed it into providers and systems so that they can fix things. So they can fill in knowledge gaps, they can know how informed people are, they can have discussions about the things that matter most. So for all three of those reasons, we've been initiating research, as I say, for a good long time. And it turns out that there are sort of three key elements to a good decision, or to what we have to do, and they're not completely integratable, but Karen's going to tell you all about that. I mean, the first thing that we've always said about a good decision is that patients should know the key facts, that there's some body of information they should understand about their choices and what the pros and cons of those choices are, that they should have. And so one set of measures we need is, do they know what they need to know? A second thing is sort of what the decision-making process is, and that's what we've sort of been talking about here. It's not enough to inform patients, at least that's been a position that we have had for a long time. Mostly we're talking about medical care. I mean, it may involve some other things that patients have to do. They may have to go take the pills that they sign up for or get prescribed. They may have to do some rehab. They may have to do some stuff about their diet or exercise or something. But we are talking about medical care, and at least we've been talking mainly about things that involve some kind of medical provider, at least considering some of the alternatives as part of the discussion. So you've got to involve and we also think of the providers as a source of information. So we've routinely thought that we needed measures about what that patient-provider interaction was about and how that worked, again, as a measure of whether things are happening the way we think they need to happen. So we need to measure what facts people have. We need to have some measures of what the interaction's like between providers and patients. And the end, the one that Al and others have held up as the measure of whether or not you have a good decision, is whether or not the decision that's eventually made aligns well with what is most important to the patients. And what alignment means can be discussed, and one of the complexities is what the model looks like about how to do that. But measuring what matters most to patients and how well the decision that are made and the options that are rejected relate to what they care about is the third piece of what you need to measure, we think, in order to assess decision quality. So the person that I know who has spent the most time thinking about this topic, has collected the most data on this topic, has analyzed the most data on this topic, and knows more about it than anybody I know, is Karen Sapuka. Karen is at Mass General Hospital. She's been working there for a long time. She's also on the faculty of the Harvard Medical School. And she is going to share with us what she's been learning over the last quite a few years. Karen?
So thank you so much, Jack. So I'm very excited to be here today to talk to you about the work that I've been doing and many others have been doing to try and measure and improve decision quality. And as Jack mentioned, a lot of the work that I'll be presenting has been funded by the Informed Medical Decisions Foundation. And so I've been very happy to work closely with them on this. So what I want to do is three things. First, I'm going to talk a little bit about a case study that illustrates some of the issues around what is a good decision. So what are we talking about? And then discuss some of the work that we've done to measure decision quality. What are the survey instruments that we've been developing? Focusing on two pieces. So Jack had mentioned three different sections. We're going to focus on the knowledge and then the matching the goals to treatments. And then I'm going to give a little bit of a flavor for how the survey might be used. Dale's going to talk a little bit more about that in her talk. So to start with a case, so this is a man, Mr. M, was a patient at Mass General, 71-year-old man who was referred to our orthopedic department for worsening right hip pain and had been getting in the way of his sleeping. And the x-rays confirmed that he had severe osteoarthritis. There was a lot of damage, good candidate for surgery. So he went to go see one of our surgeons. And the note from that visit, one clip of it was, I went over in some detail the different treatment options, and he very much wishes to proceed with the right total hip replacement. So far actually sounds maybe like a good process happening here. We went over the options, wants to have a hip replacement, so maybe we've got a good shared decision-making process going on. Don't know about your different hospitals you come from or where you work, but it takes several months once you schedule a surgery at Mass General, 3-4 months before you actually have that surgery. And in that time, Mr. M was talking with family and friends. He went to his PCP for a pre-op evaluation. And at that visit, the primary care physician realized that he was raising a lot of concerns and didn't seem very comfortable with this decision. And at the time, we had just launched this process with having decision aids at MGH. And so we said, why don't you watch this program and see what you think and let me know what you think about this. And about a week later, was CC'd on this letter that Mr. M had sent to his surgeon, saying, I'm writing to tell you at this time I will not be proceeding with my right hip replacement. Therefore, please cancel my appointment for pre-admission testing and for surgery. So about 6 months ago, I added daily biking to my exercise routine. After 3 months, found that the nighttime hip pain was gone. When I saw you in May, I wasn't sure whether that was going to hold, but it has so far. So based on a conference with my primary care physician, on viewing the very helpful information, sent to me the video decision aid, I decided waiting for surgery was the best decision. Now, we were a little nervous about what this was going to do, but it also, as we were thinking about it, raised a lot of concerns for us. Did he make a good decision to have that surgery in the first place? Did he make a good decision to cancel it? How informed was he? What were his goals? It seems in this letter that back when he was meeting with the surgeon, he already had a lot of these concerns that somehow never got raised. Why wasn't this part of that discussion? And this was really, for us, a near miss. We almost operated on someone that didn't seem to really need or want this surgery. And so how is this happening? And we didn't want it to just be happenstance that he happened to see a primary care physician who happened to remember that we had this video decision aid and happened to give it to him. It seemed a little too lucky. And so we don't want to make this a matter of luck. We want to make sure that we're doing the right treatment, right patient, right time, every time. And so we really started to think about how could we do that? And what would we need to know? If we're thinking about measuring the quality of decisions, what would you want to know to figure that out? Now, I know we've talked a lot about different definitions of patient-centered care, and there are many definitions out there, but it seems that there's some core themes that come up no matter who's talking about it, whether it's sort of medical societies, consumer advocacy groups, or policy groups. And the core themes really do reflect what I think we're trying to do with decision quality. The importance of having patients that are fully informed, the importance of treatments that reflect patients' wants, needs, and preferences, and the importance of patients playing a key role in making their healthcare decisions. And so those are the things when we're talking about what's a good decision, it's when those three things are happening. That's what we think of. So how would we measure that? What would we do to operationalize that into a measure? And we have laid out this proposal. This was now 2004, I think, when Al, Jack, and I laid this out, saying it's going to be really simple. We'll just ask a couple of knowledge questions, a couple of goals, and then we'll be done. No big deal. So 10 years later, we're still working on this. I'm diving into the survey research, which wasn't necessarily my background. But we really have focused, as Jack mentioned, did the patient understand the key facts? Is the treatment consistent with the patient's personal goals, and were they meaningfully involved in the decision-making process? And as part of survey research, one of the things we did was, talk with hundreds of patients and talk to them about their decision-making process. And a common question, if you want to know if patients are meaningfully involved, is we ask them some sort of version of this. Well, who made the decision about your treatment about breast cancer, or what role do you want to play in the decision about treatment? And you can substitute anything in for breast cancer, whatever your topic of decision of the day is. And we usually categorize it into these categories, mainly the doctor, both equally or shared, and then mainly the patient. And when we talk to patients, we're actually able to categorize what they're saying and the description of their experience into these buckets. So here's a woman saying, describing her experience with breast cancer treatments. They didn't say to me, well, we could remove the breast, we could do this, we could do that. They just said, this is what we're going to do. That was it. I wasn't in on the decision. So a situation where the doctor made a clear recommendation, there was only one option given, and that's what they did. So very, very provider-driven type of decision. And you can contrast that with this other experience another patient had. I made the decision. I'm very happy with the lumpectomy because that's what I wanted to do from the beginning. My doctors, didn't disagree. They didn't agree. They just said, okay. They understood. So really a patient coming in with a clear preference, telling that to the doctors, and the doctors, accommodating her. So a very patient-driven type of interaction. And then we also heard something that's more in the middle. So this was when, the doctor, was compassionate, gave me the data I needed. We talked statistics and sizes and measurements and things that helped me with my decision. So really, a sense that there was much of an interaction going on. There was a back and forth, a give and take, where there's probably some more shared decision making. So now what I want you to think is, when we asked these three women this survey question, what do you think their answers were? So all three of them put both equally as their response. And so this is the challenge. I think it illustrates, really for me, one of the big challenges with survey research. It is very easy to write survey questions. It is very hard to write good survey questions. And so, the challenges that we faced when we started to dive into this was figuring out how do we write really good survey questions that get us what we think. When we interpret their answers, it really means what we think it means. And so we set out a very rigorous development process to create these surveys in terms of generating the items, drafting the instruments, and testing them. And throughout, really, we're engaging patients, multidisciplinary groups of providers to define the content, to figure out the formatting, how we were doing this early and often. And we, that's probably why it's taken so long to do. But it's very, very important in that whole process. And so we've done this for dozens, probably about 20 different conditions, and done field tests for at least a half a dozen different conditions. But we've got thousands of patients who have filled out knowledge questions, their goals and concerns, and their interactions with their providers across a range of different topic areas. So several among surgical decisions, for cancer screening, for medication decisions, and we've looked at issues in underserved populations. We've translated surveys into Spanish to try and get a sense for how the surveys and this approach works across different populations and samples. So we have a considerable amount of evidence from our field tests. Surveys have also been adapted and used in large national studies, the decision studies, the trend study that the foundation has funded to look at a national portrait of what's going on with decision making. So we have a lot of experience using the surveys and the items. So what we've done, this is just an example of some knowledge questions from the survey around hip osteoarthritis decision making. And to measure knowledge, we really did focus on the key facts. And a lot of people ask me, why can't we just use some generic questions? Why can't we just ask people, did you understand the options? Did you understand the risks and benefits? It would be so much easier than trying to make knowledge questions up for each specific decision. And I agree, it would be so much easier. We would have been done, 10 years ago. The challenge is part of our field testing, we actually asked some of those generic questions alongside the decision-specific questions. And what we found was there was no correlation. It was a flat line between people's perceptions of how informed they were and their ability to answer these questions. And so it just sort of, I think, illustrates, people don't know what they don't know. If you've never had a really good shared decision-making process, it's really hard to answer how that decision was made. Was it shared primarily the doctor, primarily the patient? If you, don't know, the information about how likely it is for someone to have a revision surgery after a knee or hip replacement, you might not know that you didn't understand one of the key outcomes of this surgery. We usually have a mix of sort of gist and quantitative questions. So gist-based questions really are trying to get just the high level, which one's more likely to relieve your pain, surgical options or non-surgical options? And then a quantitative question will really try and dig down a little bit deeper to see whether they have some more realistic expectations. And it would look like, out of 100 people who have a hip replacement, about how many will have less pain after that surgery? To get a sense for whether they actually understand the magnitude of the benefit. And so we have tested these, in thousands of folks. We've looked at patients randomized to getting a decision aid or not. We've compared providers answering these questions to patients, to healthy volunteers. And we can find, pretty good psychometrics. So the psychometrics of the validity, reliability, the feasibility, acceptability. So we've looked at lots of different dimensions of these surveys and found on the knowledge side very good psychometrics for those. So they're pretty strong instruments across the board, which is great. So the second piece, and the piece that Jack alluded to, is maybe the holy grail here. How would we know whether or not we're matching the right patient with the right treatment? And the first part of that is to actually understand, well, what are the patient's goals? If you're trying to match the treatments to patient's goals. And so what we've decided to do here was focus on something that's very straightforward. When you get into the value elicitation literature, you can very quickly get into some very complicated, you need computer-assisted technology to elicit somebody's goals and values. And we wanted to focus on a very straightforward task. So we're really asking patients on a scale of 0 to 10 or 1 to 10, how important is it to you to relieve your pain? How important is it to you to avoid having surgery? How concerned are you about that? And one of the challenges of this simple approach is that someone could say, I want all of the benefits and none of the risks. We don't prevent them from doing that. And they can't get that in the real world. They have to make trade-offs. That's why these decisions are often hard. But what we found, and we have thousands of people have answered these, that's not the common response. That's not what we found when you roll this up over a group of patients. You don't find that everybody says 10 on the benefits and 0 on the harms. So we really have found that for each of the topics that we've looked at, usually 2 or 3 of these items kind of bubble up to the top. And when you're looking across groups of patients, you can find 2 or 3 questions that really do seem to discriminate among patients who might choose among different options. And that can be very helpful. Focusing on sort of the key consequences, both good and bad. Now, there is a challenge here in terms of the timing of the assessments. Clearly, what we find is that patients' goals change over time. They change with information. They'll change as their disease changes. And that's okay. So I think what we need to think about is this isn't just sort of a one-shot deal. You get your goals once and then you're done. This is something that's going to need to be thought about over time at different points in time with the disease, that we need to keep checking in to figure out what's important to patients and how that might evolve. So we're not done once we elicit their goals, because then we actually have to figure out, well, which treatment are they lining up with, and do the patients get treatments that match their goals? So for a simple example, what we've done for hip and knee replacement, your goals can line up with having surgery, your goals can line up with non-surgical options, and then either you had surgery or you didn't have surgery. So we can look at where they match. Your goals lined up with surgery and you had it, great. You get your green check mark. And vice versa. Goals might line up with non-surgical options, and you have non-surgical options. Now, the other ones might provide some evidence potentially of overuse or underuse, where there's a mismatch. And when we did this with a sample of about 400 patients with hip and knee osteoarthritis, and they were recruited from 4 different sites, here's what we found for the big results. So we did find that about 2/3 did get care that was pretty consistent with their goals. And we found about 1/3 didn't. Most of those were actually on the underused side, patients who really wanted to have surgery, but their doctors were sort of giving them the message that they were too young, they weren't ready yet, they should wait. Although there were some also that had surgery where their goals really suggested that they were leaning towards non-surgical options. And now, as Jack had mentioned, another question that we get a lot is, well, what's your final score? Like, what's your final decision quality score? And there is a sense that it's important to have all of these things happen. You want them informed and getting treatments that match their goals and being meaningfully involved. So we did look at that with this sample of patients with hip and knee osteoarthritis. And we set a cutoff for knowledge at the score. We had a sample of the patients who had watched a decision aid, and we took the average score of a sample of patients who watched a decision aid as our target. That was sort of our target threshold of a pretty informed population. And we looked at how many of these respondents met that threshold for knowledge and got treatments that matched their goals. And about 1/3 of them, a little less than 1/3, met both of those criteria. So clearly we have some ways to go in terms of reaching this ideal of delivering high decision quality. And when we looked a little bit into the data to try and figure out, well, what's sort of associated in this sample, at least, with having high decision quality, one of the biggest predictors was the site. So we had 4 different sites, and one of the sites was Dartmouth, where the patients really had used decision aids. And they were, very high up on our decision quality metric. So that's good. The other was their involvement score. So we did ask them about the interaction with their doctors, and patients who had more involvement with their, in more sort of a shared decision-making process were more likely to have higher decision quality as well. And then having had surgery was also another predictor. And the other thing we looked at was the association between high decision quality, and it was linked to less regret and more confidence in their decisions. So good things we think. So how might we use these surveys? What can we do with that? And I think Jack alluded to some of these, in terms of the purpose of measurement. And clearly there's a big area in research where these can be used to evaluate decision aids or other decision support tools, different kinds of processes. And there you want a survey that's very detailed. You can often deliver it or administer it in very controlled settings. You can, thread the needle and get it just at the point where the patient has just made their decision, perhaps. And so we do have a long version of all these decision quality instruments that are available for use for research purposes. When you move into the clinical practice, we have heard a little bit earlier from Charlie at Dartmouth that they survey patients, and we'll hear a little more from Dale, maybe before the visit, and then feed that information forward to the clinician to sort of identify knowledge gaps, elicit patients' goals so where they're thinking before the visit. And there they want, short, actionable, feasible, acceptable. Very short is usually the biggest goal there. So we have short versions of the surveys that can be used in clinical practice. And then the last piece is accountability. How would we use this to sort of measure performance and compare performance? And I want to talk a little bit about something that's kind of exciting that's starting to roll out at Mass General along those lines. So Mass General is part of Partners Healthcare, and Partners is one of the pioneer ACOs. And this is a slide that I took from Tim Ferriss. And the nice thing about it, I think, it's as he's trying to describe our ACO strategy for improvement and care improvement. And right in the heart there is shared decision-making and clinical appropriateness. So we like to think that we're at the core of their ACO strategy, at least at the center of their picture. And how they're sort of making this concrete is looking at decision support for high-cost elective procedures. So the ACO, they've picked 6 different high-cost elective surgical procedures and have linked or really expanded the definition of appropriateness to include both someone who's clinically appropriate. So they've actually worked collaboratively with the providers. For example, this is an example in carotid artery disease. So they've worked with the providers to define or adopt national guidelines if they're available, or define our own guidelines for who's appropriate for these different procedures at which point in time. But they didn't stop there, and that's the nice thing. The second thing that providers now have to do before they can book an OR is actually confirm not only that someone was clinically appropriate, but that the person is informed and wants it. And so right now that's operationalized as has a decision aid been given. So this says has a decision aid for the procedure been shared with the patient. And what we want to build in as this rolls out more, we've just started piloting in the spring, would be having actually their decision quality, that they were informed and they want this procedure, so that that gets checked off and just pulled in because the patient's already completed that earlier in the process. So this is sort of one way where we could be thinking about this in terms of a system-wide accountability. How do we know that every patient in our hospital not only needs this procedure but wants it? And this is sort of one of the ways that we're thinking of trying to put that into practice. So just to give a little bit of the B story for Mr. M, because the story doesn't end. This is a chronic disease, osteoarthritis. And for him, 2 years later, the pain started worsening. And his nighttime hip pain came back. And he ended up going back to the same surgeon and had the hip replacement surgery. So he had a good result. And I think his primary care doc was feeling a little bit torn. Did I just put him through 2 years of extra pain? Did he regret it? Should I have just had him do it, in the first place? And so we asked him, and Mr. M was very clear. Yes, I'm happy that I had the pain relief. I've got good function now, but I don't have any regrets. It was not the right time for me 2 years ago. It's the right time for me now. And so that, I think, made us feel very good about the process and the project. So just a quick summary. We do have well-tested decision quality survey instruments for many common topics. They're available free for download from our website. And I think they're really at least a start to try and figure out how do we provide some accountability that we've reached the right patient with the right treatment at the right time. So I think we're...
Let's. So why don't we? I think we can take questions for a few minutes, and maybe just exercising my responsibility, I'll start the questions to give you something to think about. I know you mentioned one of the things we've wrestled with the most is different ways of putting together the things that people care about when it doesn't all line up, and almost all of the sort of the definition of a preference sensitive condition is there are upsides and downsides from somebody's point of view. They're not clean. Maybe you could just talk just a bit about different ways people have tried and you've tried to put them together and where we are in that.
Yeah, and I think so I think what Jack's referring to is how do you take the goals and then put that into that nice little box where it says goals suggest surgery or goals suggest non-surgical options. So what's that black box in there? There's a couple of different approaches to doing that, some being very straightforward to others being very statistically oriented and mathematical. So we've started looking at a regression model where we say, what we're trying to do is predict surgery. And the independent variables are going to be the goals. And so how much of the variance in the treatments are explained by the variance in patients' goals to see whether or not we're tailoring treatments to their goals. And usually when we do the regression model, and you can control for other factors that might be relevant in different clinical situations, should appropriately drive care. But then that can help you understand, at least at the population level, what are the different factors that really do discriminate among patients who choose different options. One approach that we've used is the regression model, and then it comes out with a predicted probability of surgery or whatever the treatment is given that patient's goals. If it's high and you've had surgery, then you can consider yourself matched. If it's low and you don't have surgery, then you can consider yourself matched as well. Other models, a lot of people just add up the pros and cons. And if the pros outweigh the cons, if you're in positive territory, you're leaning towards surgery. If you're in negative territory, you're leaning away from surgery. And then other folks still have just looked at, you can just ask the patient. Instead of going through all of their details of the goals, just say, well, which treatment are you leaning towards? And if they can kind of put it all together in their head and they're leaning towards surgery, you could also just look at a simple match between their treatment preference stated directly and what they have.
Right, and the complexity even gets greater because some people make it on one thing, even though they've got pros and cons about a lot of things. They just key on one thing and they say, I just absolutely want to get rid of the pain no matter what, or I want to do the most I can to treat my cancer, no matter how much this, and that's not necessarily a bad thing, but it makes it harder to calculate. And then finally, the problem of getting a score that you can show anybody that they could understand. A regression equation that is not easy. Yes.
First of all, thank you. It was a fascinating presentation and very thought-provoking. And I'll have to apologize in advance because I haven't read through or viewed as many decision aids as I need to, but I will make that my homework. So this may be a question that many people know the answer to, but I'm curious, in the decision aids that are being used for surgical procedures, for instance, have we gotten to the point where publicly reported data on things like surgical infection rates at specific hospitals are being shared with patients so that it's not just, do you want to have this surgery or not, but do you understand that if you have this surgery at this site, that this is your likelihood of potentially getting an MRSA infection? So that level of data, I was curious about that.
You want to answer?
So I'm not sure actually if they don't, they might exist somewhere. I know the foundation decision aids and the ones that we've been using are fairly general. So they use published evidence in terms of looking at side effects or complication rates. And then I think the idea and what we've encouraged, some of the surgeons that we work with at MGH, if they say, well, I don't want to use the published rates, I want to use ours, and they actually have the registry data and they can pull their last 1,000 patients and look at their revision rate or whatever it is, that it's sort of a little sheet they can put with it, and here's what's happening at our site. I'm not sure if people are putting in the MRSA rates and other things, which would be interesting in terms of choosing a hospital and where to go get the rates.
I really do think it's something, if we're not already doing it, we need to be linking that data up, because my observation from talking with many patients is that they have no idea what the risks of simply being in a hospital are. And they think, oh, the longer I'm here, the better. So having that ability perhaps to add a little additional patient education about the real risks, I think would be wonderful.
Yeah, I agree.
Yeah, thanks.
That's great.
Mark?
Karen, it's always a delight to hear about your work and how it's progressing. It's one of my hypotheses about some of the challenges with getting shared decision-making more widely adopted is that it seems to me that this problem, or these twin problems of unrecognized patient ignorance and preference misdiagnosis, is largely invisible. Patients aren't aware of it, and doctors are clearly not aware of it. And from looking at it from a population standpoint, it seems to me if we had a good measure of that and we could publish it and start talking about the burden of unwanted care, for instance, that might get people more motivated to pay attention to this, both on the patient and provider side. So, long-winded way of asking the question, what is your thinking about good ways to measure this at the population level in terms of, measuring decisions? Are they informed and are they preference concordant? And I welcome your recommendations because we'd like to deploy such a measure in California.
Yeah. I think it's a great comment, and so far this has really been more in the research-y kind of world in terms of trying to develop the measures and make sure that they're robust enough to kind of stand up to the scrutiny that would come if we started to really say this is, now we're talking about the quality of care and comparing providers and practices. But certainly the studies that we've done, when we ask patients on a scale of 0 to 10, how informed did they feel, 40% put 10 out of 10. And another 20% were 7, 8, or 9 out of 10. And yet, I think 0 or at least 50% of the patients got 0 or 1 question right when we asked them 5 knowledge questions. So just the huge gap between what they think they know and what they actually know, it's enormous. And then, even some of the studies that we've been, looking at in terms of how common is it that patients might be getting treatments that they wouldn't have chosen, maybe 1 in 3 for our surgeries, and that's pretty big. I think one of the ideas is to pick a couple of topics, whether it's surgical, that's kind of easy to find. We got to figure out how to find people who've made these decisions and survey them in a reasonable amount of time so that we can be confident with those results and start to publicize this. But in a way, I think that we would say, but we actually have ways to improve this. There are decision aids available. We know actually how to help people make good decisions on these topics. So it'll be nice to have not just to say you guys are doing a terrible job, but to say, and here's how we can do it better. So to use it as sort of learning and improvement, as opposed to sort of the, just for a kind of a punishment or in that view. So I think that would be important. How do you frame it? So I don't know. I'd be happy to work with you on that.
Al?
Yeah.
Al Sox from Dartmouth. So your last slide talked about well-tested decision aids, and I wanted to catch you up on that well-tested word. And it's a characteristic of a science that it can predict the future, some future event accurately. And I wondered how you measured the ability of a score, for example, on the decision quality measure to see how good a predictor it was of the future.
And so predicting, what kind of things would you want to predict?
Well, I was hoping you were going to tell me that.
So the things that, the kinds of things, and when we were saying well-tested, so the kinds of tests that we were running on the surveys were to figure out, when someone answers the question, do we interpret it the way that we, the patient meant it? Is it a reliable survey? If you give it to them twice, do they give you reasonable answers both times?
Which they do.
Yeah. And so, in terms of understanding that predictive power, we have linked it to regret and decision outcomes, regret, confidence, and those sorts of things. I think there's sort of more research to be done to figure out, in certain conditions, are people who are better motivated, understand their decision, more engaged, getting treatment that they want. Does that lead to better adherence and other things? So those studies are still to be done.
So regret is, say, your gold standard. And how well did it predict regret? Did some result on this measure predict regret?
I could get you the numbers.
Okay, we'll talk later.
Yeah.
Yeah, I mean, there's a paper actually that just came out about a discordance measure that did predict well both regret and, I mean, would you do it again? And pretty well. I mean, it's significant and stuff with a lot of other things going on. And also the decision process scores also predict regret pretty well. 12 out of 14 decisions last I saw. So the constructability data are around, and there's a lot of other variables that make it hard to make it blow away. But we're accumulating data. We're worrying about that, and I think we've got a pretty good body of data on that topic.
Well, thanks.
Two more, and then I think that's it. David?
Hi, I'm David Biroff, Health Dialogue. I was actually going to ask about regret, too, so I got on top of that. But I was just struck with the power of that statement from Mr. M saying no regrets. So it seems like a great outcome.
Al, you get the last word, which is appropriate for this topic.
Just very quickly, I wanted to comment on Marcus's question and expand a little bit on the answer and relate it to this reframing of preference misdiagnosis. I think most of the clinicians in the room can remember at least one occasion when they were students or residents when they were shamed for having missed a diagnosis. So what we're trying to do with this reframing is to say that the preference diagnosis is every bit as important as the disease misdiagnosis. And if that's the case, we ought to be measuring and recording and reporting loudly the prevalence of preference misdiagnosis in different settings. And actually, if you think about that as being a task, it's relatively straightforward to do. It's more straightforward than the complex measurement of decision quality that we've been hearing about. You just identify a well-defined subgroup of patients in a particular setting, and here they are going off to surgery because a preference diagnosis has been made. And then you take them through a process where you work really hard to elicit their preferences and see if it changes. If it does change, it's a preference misdiagnosis. And the notion that if you could get multiple sites looking for the same preference the preference misdiagnosis for the same conditions and the same decisions, you could really get inside the head of all of us physicians who were shamed for missing a diagnosis when we were in training, is, I think, one worth pursuing.
Thank you. Great. Thank you very much, Karen. And And now we get lucky some more. You've already been introduced to Dale, so I won't do a lengthy introduction, but she was head of the Breast Cancer Center, or maybe you still are. Anyway, I thought you moved on. But anyway, when she was head of the Breast Cancer Center, I think she initiated one of the most innovative, programs of using shared decision-making on a routine basis. And then she also added the collection of data related to decision quality and tried to get that integrated into cancer treatment decisions and interactions with physicians in a wonderful way. And she has done a lot of other things, including being head of the shared decision program up at Dartmouth, and she's going to share her thoughts right now. Gail Vidal.
So I have about 20 minutes worth of slides, and we were going to do 10 minutes of discussion. Since we have now about 20 minutes total, I'm going to do a radical surgery on my talk, which you're only going to benefit from. I think instead of going through some of my early slides, I'm going to just sort of briefly describe my experience at Dartmouth around shared decision-making, which will help set the stage for the 2 key slides in this whole talk. So in 1995, I came to join Dartmouth-Hitchcock because of that man, Jack Winberg. I was being recruited there, and it was not until I found out that Jack was there that I was sold on the deal. I came and did my master's at TDI, then CECF, over 3 years, and in 1998, my final project, my capstone, was to help design the workflows for the Spine Center, where we were implementing patient-reported outcome measures and shared decision-making. In 1999, I took over the Comprehensive Breast Program and decided to try and redesign the systems of care there as well. And it was really based on my experience with the Spine Center and working with Paul Batalden, who was just a wonderful person in healthcare quality improvement. And one of his main messages to me was, if you want it to work, it's got to be easy, and it's got to be reliable, embedded in the daily process of care so that it works the same way every time. And pretty much everything that I do in healthcare, I hear those words and think about that. So we did redesign the care process, and you heard Alice sort of comment about her experience with the breast program, and I'm really proud of how the patients experience breast cancer care at Dartmouth, because when we started, it was tragically bad. There were people who got their surgery and never made the link themselves to get to radiation oncology and missed getting radiation in a timely manner because there was really no care coordination. Now we have this wonderful process where every patient who's diagnosed with cancer gets a decision aid that's appropriate for them, because we've created algorithms for our support staff to make that happen. So I deliberately bypass the physicians because it is, I'm a practicing clinician. It's really hard to add one extra step, and so for it to consistently happen, we kind of just take it away from them. In 2002, Jack actually gave me a small grant. I doubt he even remembers it. But I used that small grant to design a program to try and get at another issue, which is, really how well is shared decision-making working in the breast program. So we designed over 2 years a comprehensive set of patient-reported outcome measures and an assessment of decision quality, which I'll get to in just a second, as soon as I can find that right slide. And by the way, one of my collaborators, Lisa Weiss, is in the back of the room. We worked many years together on those patient-reported outcome measures. Okay, somebody may have to help me. I'm not a Mac person. I want to move forward way ahead in my slides. Anybody? Okay, I'll do this. Okay, here we go. And how do I go full screen?
Full screen.
Oh, I'm full screen. They're good. Sorry. All right, perfect. So, just a little backstory. In 1993, an NIH consensus panel decreed that the recommended treatment for most early-stage breast cancers should be breast conservation. And I saw a lot of patients who had chosen mastectomy because they don't come to me, the plastic surgeon, if they've chosen breast conservation. They come to me if they've chosen mastectomy. And I felt I'd seen enough women who seemed to be making an informed choice about that I thought it was probably worth looking at that. So one of the purposes of the study in shared decision making was actually to determine if the women who chose mastectomy really were making an informed choice for a decision that some people couldn't really understand. And you've heard a lot of this, so I'm skipping all that stuff you don't need to know. And basically, this is our report on decision quality that came out of that study. We asked patients, sort of off the top there, what are they leaning toward? In this case, the patient said mastectomy. How sure were they about that choice? No, this patient was not. What do they understand about knowledge? This patient actually got both of the main questions wrong, which is survival rates are pretty much equivalent whether you chose mastectomy or breast conservation, and the recurrence rates are similar. So she got both of those questions wrong. And these are her values for different aspects of the outcomes of surgery, keeping their breasts versus removing breast for peace of mind, for example, and many of the other topics that Karen helped us come up with. Thank you, Karen. So that's their values. And in our study, the patient knowledge, having watched an evidence-based decision aid from the foundation, by the way, have to thank the foundation. Over the past 5 years, we've distributed almost 25,000 decision aids at Dartmouth thanks to the support of the foundation. So we really want to acknowledge that. So the knowledge questions post-video and post-consult were very good in this group of patients. And Karen did a concurrent measure at a hospital in Boston who will remain nameless, and I believe the knowledge scores of women who had actually had surgery and made the decision were around 50%. So obviously the decision aid was doing a better job than some of our very best doctors at providing patients with good knowledge about treatment choices. And this is what their values look like. So on the top half of the screen, you see patients who chose lumpectomy. And those are their values and the average scores of the women who chose lumpectomy across all of those values. And down below, patients who chose mastectomy. And you can just see from the patterns of the scores that they're very different. What women value if they choose mastectomy is a very different pattern than women who chose lumpectomy. So how many women do you think choose mastectomy? I mean, for those who would choose breast conservation, it's hard to imagine somebody might choose to remove their breast. I mean, do you have in your own mind an idea of how many women might choose a fairly radical choice when they're clearly well informed? Does 35% surprise you? Yeah. So we did that logistic regression that Karen mentioned on these scores. And on the left side, you see the patterns for women who favor breast-conserving surgery, and on the right, mastectomy. And what you will notice that the scores that are significant are remove breast for peace of mind if you choose mastectomy, and keep your breast if you chose breast-conserving surgery. Now, that's one of those findings that is like, duh. When you have it, it sounds so obvious. But in fact, at the time we did this study, really around the country, there was very little support for women choosing mastectomy. This is actually from a major academic medical center on the East Coast who started presenting their rates of breast-conserving surgery, because in 1995, when the Dartmouth Atlas came out and demonstrated wide variation in the rate of breast conservation, including rates of breast conservation of 1% in Iowa at that time, it provoked such a fury that breast conservation became a quality measure for breast cancer surgeons. And this institution started tracking them when their rates were around 70, not too much different than what our study found. And the rates got up to 99, almost 95% by the end of when I stopped capturing this data. So I will tell you, I presented this data at a previous research meeting of the foundation, and a journalist there told the story of her mother in California. I think she was in a nursing home, but an elderly mother who was diagnosed with breast cancer and who wanted a mastectomy. And her surgeon refused, and so she found a second surgeon, and the second surgeon refused and told her, you really don't need anything that radical. Breast-conserving surgery would be a better option for you. They did the lumpectomy. Lo and behold, margins are positive. Re-excision, lo and behold, the margins were positive. She finally ended up with a mastectomy and was so angry about the experience she wanted to sue both of the other surgeons. So I think, another thing that Paul Batalden told me that I always keep in mind is be careful what you measure, because whatever you measure is what you're going to get. So as you go forward in your lives, thinking about how you're going to implement things like shared decision-making and quality metrics, think about the impact that you're really going to have there. Because this academic medical center was clearly, I think shifting the patient's preferences likely and not really addressing their true undisclosed preferences for treatment is my guess. So hopefully that won't happen at your medical center. And let's see, I think I wanted to go back to this one slide last time. This. So this is a true patient of mine. She came to see me about breast reconstruction, not the treatment choice for breast cancer surgery. And I'm glad I looked at this, because this is not about the treatment choice that I was going to be discussing with her, but the treatment choice for early stage breast cancer. But I knew enough about these reports by now to recognize that this was not our typical pattern. 95% of our patients got those two questions right. And for somebody who highly valued keeping her breasts, she was leaning toward mastectomy, so I already knew the results of our research study. This report just did not line up. And so instead of talking to her about treatment choices for breast reconstruction, we had a conversation about her understandings of the treatment choice for early stage breast cancer. She went back and watched the video a second time and ultimately had breast conservation. But I can guarantee you, without this report, I would have never known that, because she had already passed the normal barrier to be in my office talking about breast reconstruction. She had had the meeting with the breast cancer surgeon and already made that I'm going to go with the mastectomy sort of conversation. And I would never have known without this report. So those are the key points that I wanted to make, and I think I've made it well below my 20 minutes and probably left about 5 minutes for questions.
You've done an extraordinary job.
Okay. Any questions?
Thanks, Dale. I'm also remembering that at the UCSF breast cancer program, which has a similar approach and actually adds the students helping patients navigate the system, that the percentage choosing mastectomy was about the same, around 35%. This is fascinating because in many ways what Jack has talked about through the years is, with all this geographic practice variation, is involving patients the way to find the right rate. And we need more research to figure that out. But the fact that on both coasts, taking women through this process could get you to maybe the right rate question is really fascinating. It comes up in the Cochrane trials as well, where there were 2 randomized trials of using our BPH program, one done in the United States, where baseline rates were relatively high and they dropped, but one done in the UK where baseline rates were relatively low and they increased. So this holy grail of could we get to right rates through this process? I don't think we've nailed it down, but it's as good an approach as anything I can think of. Maybe we'll hear more from Jack on it tomorrow.
Yeah, just in the UK, when I was visiting there, there was one center that had high rates of mastectomy, and they were concerned about it, thinking that it reflected a problem with their medical center, but they felt confident that they were doing a good job at informing patients. So somebody did a study looking at the high rate center and the low rate center, and it turned out the patients at the high mastectomy rate center were actually more informed and engaged in the decision making than in the low rate center. Sometimes not what you expect.
So I've got an idea for how to get the right rate. These numbers are kind of like utilities, which are a quantitative measure of a person's feelings about being in a particular health state. They could be plugged into a decision model to tell you the expected utility of either of the 2 treatments. And if you did that for 500 women who gave you this information, you would know the proportion for whom the preferred decision, if your criterion is choose the option with the highest expected utility, and you'd have the right rate.
And it's as simple as that. Thanks, Hal. Yes.
Thank you. Very interesting talk. I'm curious about 2 things. Number one is, how much does it cost to provide everyone with a decision support tool? And the second one is, a lot of times when I see a woman who's trying to make that decision, she's just been told she has a positive mammogram, her immediate reaction is cut everything off. And I'm curious about how many of your women, or the women who use the support tool, actually changed their mind when they went into it, and did you measure what their decision was before and after?
We did. We measured a pre-decision aid leaning, and a few women who chose mastectomy in the beginning switched to breast conservation. Mostly women who were just unsure of their treatment choice moved into breast conservation. So there was a treatment switching, but it wasn't really very dramatic. And it was generally from mastectomy to breast conservation. And I agree, a lot of women have that early reaction of just, I want the most radical, aggressive treatment, which is why I think we had a hard time always supporting women who chose mastectomy. If you were concerned that they were making that knee-jerk decision, you certainly wouldn't want them making it without a little more discussion.
Dale, maybe I have one question. Maybe you could describe the process by which you collect the utilities and the knowledge scores from the patients and get them to the patients, just the mechanics of how that's done?
Well, it's actually currently interrupted, sadly. When we switched to Epic, we transitioned away from our partnership with Dynamic Clinical Systems. Lisa Weiss is no longer at Dynamic Clinical Systems, but at the time was a co-founder and partner in that company, and we worked together with them to develop the electronic survey system. So everything was electronic, and patients completed, I didn't show it, but they completed a comprehensive health survey as well that included family history, review of systems, past medical history, comorbidity assessment. It was a fairly comprehensive medical assessment as well. So providers would get a copy of the full report, both that comprehensive assessment of their patient-reported information as well as this measure of decision quality. And the whole process, the survey process, including the research piece of it, took about half an hour, which, depending on how you look at it, is more or less burdensome. But I think generally women with breast cancer were not troubled by taking the time to do that. Okay, well, thank you very much.
Very good. I'm sorry I cut you short.
Oh, that's okay.
You did a great job of adjusting.
Oh, can I say one more thing? Please. Okay. I just remembered. I just wanted to tell you one more thing. In the last presentation on implementation, 5 of the 6 cases that were presented are going to be published in a book called Are We There Yet? And if you are interested in it, you can email glennelwyn@gmail.com or look at the Twitter feed out of this conference, and I think Alice Andrews posted the connection.
Thank you, Dale. So I'd just like to thank all our presenters and all of you in the audience for the great discussion that's followed every presentation. We've been taking notes. Ideas about how to align incentives have been coming up. We're going to focus on it even more tomorrow. We're going to hear about a couple of larger demonstrations that have been done addressing the question of bringing things to scale. We will address some of the issues of cost in those presentations as well. And I actually just want to add another note. A number of presenters, including Dale, thanked us at the Foundation for providing decision aids and decision support. I'd like to in turn thank our colleagues at Health Dialogue. We've got a long history of a partnership that actually co-produces decision aids together. And that's been a fruitful partnership, and really my thanks to them for helping make all this possible. So I'll just end with a quick story around aligning incentives and making dissemination work faster. I get the sense here there's a bit of preaching to the choir. Despite this being a very eclectic audience, there's a lot of enthusiasm for the idea, but you've heard how it can be challenging to make it happen. And a lot of that is about incentives, but not just financial incentives. We've heard a lot of ideas, Larry Morrissey talking about developing, at least as I heard it, pride in patients wanting to stay in Stillwater for treatment because they were being really patient-centered, and this was a way to express that to patients, just kind of one idea. I'll contrast this because, sometimes, and I really think, yes, more study is necessary in how to do it better. The Cochrane review that's going to be updated soon is going to have 110 randomized trials of decision aids being supported by supporting a shared decision-making process, showing improvements in decision quality. And I'm wrestling with what other interventions in medicine have that kind of evidence base and yet are still pretty limited in their implementation. In my research around, for example, prostate cancer care, I think of robotic surgery for men with localized prostate cancer, a technology that over 5 years has become more or less the standard of care with no randomized trials, and the only clear data, at least in my view, of it being more expensive. So something's wrong with that picture. It gets around incentives. It's not just financial incentives. Maybe food for thought for the cocktail party that will be happening right outside these doors here, starting at 5. We can talk further, and then we'll come back tomorrow, again, refocusing on the question of how do we make this happen faster? What kind of incentives, not just financial, but more broadly? Thank you all for your participation, and we'll see you in a little bit.